Everyone, I'm delighted to be facilitating the second session of the Shared Maternity Care Collaborative Workshop. Thanks for attending this evening. I'd like to start off by acknowledging the North Western Melbourne Primary Health Network, the Royal Women's Hospital, Mercy Health, Northern Health and Western Health. Would like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Woi-wurrung people, the Bon Wurrung people and the Wutharong people. We pay our respects to elders past, present and emerging, as well as pay our respects to any Aboriginal and Torres Strait Islander people in the session with us today. Just some housekeeping. All attendees are muted. Please ask questions via the Q&A box only, not via the chat box. Please feel free to chat amongst yourselves respectfully in the chat box, but please, if you could ask questions in the Q&A box. The session's being recorded, and you'll receive a link to the recording as well as a copy of the slides in the post-session correspondence along with your CPD certificates. Questions will be asked anonymously to protect your privacy, and often I might answer questions actually in the Q&A box or present them live, often in a thematic theme. Please ensure you've joined the session using the same name as the event registration or the phone number if you've dialed in, and so that North Western Melbourne Primary Health Network can use it for your CPD. If you're unsure if you have, just in the chat box, you can let them know what your name is on the Zoom versus the name that you've registered with so that they can actually link those, or else you can email them after an event. I'd just like to start off actually thanking the North Western Melbourne Primary Health team that always facilitate these events and actually help them so much, and in particular that's Vanessa and Yvonne today, and also for the outstanding work that North Western Melbourne Primary Health Network do in actually supporting the GPs and primary care capacity of the North Western Melbourne Primary Health region. So just some contact details, and these will come out in the slides afterwards. The Shared Maternity Care Collaborative actually consists of 4 hospital services: Northern Health, and that's Kira McGaw, and our new GP liaison officer there, Richard Sayre; Mercy Health, Caitlin Shaw and Sharon Chisholm, who did a lot of work this evening as well; me and Emily Lawson at the Royal Women's, and at Western Health, Dr. Joseph Wilson. Thanks to everyone. Just a few hospital updates. The first thing is just to remember to actually update any GP details for yourself and anyone else in your practice on the National Health Services Directory. This is really important because this is the database that's used by almost all hospitals for their own databases so that they can communicate with you. And please, if you could just get your practice manager to put it on a tick box so it's a routine thing when new GPs are coming or GPs are already in practice. Mercy Health now is accepting referrals by e-referrals, so that's absolutely fantastic. And I think as GPs we all know the benefits of HealthLink referral. It's usually on your practice software. It auto-populates. It actually indicates what issues are mandatories and what's not, and you have an audit trail within your practice as well. So please have a look at their website for similar information. With Northern Health, just again a reminder for National Health Services database, because they're now sending their discharge summaries digitally via HealthLink. And they've also got this fantastic new community virtual consultation service that's providing like a secondary consult advice for general practitioners in paediatrics, endocrinology and rheumatology. So once again, check it out, provide feedback so that there's an iterative improvement in that, but we're very delighted to be providing that. At the Women's, we're delighted to announce our new public fertility care service, which is a free service for women. And that's fantastic because it will increase the access for fertility treatment to so many of the women that we see. And we've got a new home birth program, which Vicky can talk about. And the program started on the 7th of the 12th. It'll be for low-risk women, and they'll initially be in a caseload midwifery care. Eligibility for home birth will be determined at 36 weeks by the hospital doctor. And after that, the suitability of the home environment and access to the home environment will be made. So there'll be very strict criteria and a very strict sort of support process around that. For more information, sorry, I popped that in the wrong spot, but for more information on eligibility criteria for the for genetics for the fertility service, please see that. Also, a reminder to sign up for GP News if you can, if you haven't got it. So just a quick word on health pathways. I think many GPs are using health pathways, and in the last annual report of North Western Melbourne Primary Health Network, there were over 1 million views of health pathways by the North Western Melbourne Primary Health Network GPs and health professionals in the previous year. And that's up from just a few thousand only a few years ago. They're pathways that are written by GP clinical editors in support with other subject matter experts. And as you know, they have many sorts of issues that are covered, and it's easily accessible at your desktop. So the sorts of things that are relevant to the session today is the genetics, prenatal screening and diagnosis, fetal abnormalities, preconception assessment, pregnancy, genetics.
Navigating health pathways.
Sorry.
Visit the Health Pathways Melbourne website and
sorry. And also there's a whole lot on shared maternity care. There's lots in obstetrics, antenatal care, pregnancy, bleeding, recurrent loss, but you'll go through those. All of these have links to them. So when they're sent to you, you can actually grab the links for the information and the referral process there. If you're not currently registered for Health Pathways, it's for free. And if you could please register in this way, great. And feedback, there's a lot of iterative development for that as well. So this is a little bit about me. I'm a general practitioner and I have a number of other roles, but in this capacity, I work at the Royal Women's Hospital and lead their GP liaison unit, very small GP liaison unit, and also assist with shared maternity care. And I have the great pleasure that Vicky is my boss on a Wednesday when I also do an antenatal clinic with the Yellow team. The two speakers today, Lisa Hugh is going to be talking about prenatal screening and and a NIPT test. What's the current standard of care? So certainly something that's evolved and continues to evolve over the last few years. Lisa is a maternal fetal medicine specialist with special interests in prenatal screening and diagnosis, particularly the use of cell-free DNA for the detection of fetal chromosome abnormalities. She's a director of genetics at Mercy Hospital for Women, and she sees patients in rural areas as well. She has an MRFF investigator fellowships into genomics. She's a team leader in reproductive epidemiology at the Murdoch, and she's very active in the area. And I know at the moment she's doing a lot of work in CMV syphilis as well. And as I said, Vicky is one of my, I'll count her as my friend and also a mentor in Yellow team. She certainly teaches me a lot. She's a general obstetrician with a high interest in high risk obstetrics. She works both privately at Francis Perry and as a leader of the Yellow team. She's got a very strong interest in Indigenous women's health and has led the Reconciliation Action Plan at Women's. She has a strong interest in improving outcomes for women with previous birth trauma, and actually tasked the set up the COVID ward extremely efficiently over a number of days when we were having those challenges 2 years ago. And she's a current medical lead for that program. So I'll do this at the end, which is a session conclusion. So over to you, Lisa. Thanks very much.
Okay, thank you very much, Inez. It's a great pleasure to be here tonight. I think this is the first time I've given a talk to this group, so I hope what I've got to share will be of interest. I hope you all learn something, because I know NIPT is not new to all of you. It's been around now for 10 years in Australia. So I think what I wanted to talk about today was really just some of the changes in NIPT, you know, all the increasing number of products that are out there with expanded NIPT, and just give everyone a bit of a sense about what is considered kind of standard care, what's considered extra, and perhaps answer some questions about some of the newer options out there. So, of course, prenatal screening and diagnostic testing for fetal chromosomal and genetic conditions has been part of routine care for a long time. And we should be offering some form of screening for trisomy 21 to all women, regardless of their age or background chance of having a baby with this condition. So that's nothing new. This is these are just quotes from the 2015 or not, sorry, 2019 RANZCOG statement. It's in the process of being developed, updated. So as I'm sure you probably remember, we've had lots of different methods of screening for chromosome conditions, and because Down syndrome is the most common chromosome condition that we see in children and adults, it's been the main focus of prenatal screening. And since 2013, we've had non-invasive prenatal testing, or NIPT, as one of the several options available to pregnant women. So before NIPT came on the scene, combined first trimester screening with the nuchal translucency ultrasound and serum markers was the most common aneuploidy screening test. So yeah, it's hard to believe it's already almost 8 years old, this statement. But even back in 2015, we looked at what was happening in the field, and I was on the Women's Health Committee when we updated the statement and recommended that either first trimester combined test or cell-free DNA-based screening were acceptable first-line screening tests to offer women in first trimester. And there are some countries with public health systems that have moved entirely to NIPT as the primary screening test. So this is the Netherlands model. So they now have publicly subsidised NIPT for all women. There's still an out-of-pocket cost, but it's a state-sponsored program. They have NIPT at 10 to 12 weeks, and they don't have a 12-week ultrasound. Women with a high risk result or high chance result get offered diagnostic testing, and those with a low chance result have no further testing. And interestingly, they do not screen for sex chromosome conditions because that's kind of explicitly forbidden by their legislation. So what's happened in the Netherlands? Well, as you would expect, it's actually led to good detection of the chromosome conditions, but there have been a few unintended consequences along the way, and that is that some major structural anomalies are now not being detected until the 20-week scan. And that includes things like anencephaly, gastroschisis, limb reduction defects, and fetuses with multiple anomalies. So that's been a bit of a concern to some of the people in the Netherlands, and there are some academics now advocating that the first trimester anatomy scan should be reintroduced. And that's because the nuchal translucency ultrasound has become more than just a scan for the nuchal and the nasal bone. It's actually an early anatomy scan. And other centres have shown that if you do that first trimester scan with a structured protocol, it really improves the detection rate for these major chromosome conditions. So this is a picture of a first trimester fetus with very large omphalocele. This is an anatomical checklist which the International Society for Ultrasound in Obstetrics and Gynaecology publish as kind of your what should be assessed and confirmed as normal if you're doing a first trimester anatomy scan. So you can see there's quite a lot of structures there, including lips. You can count fingers. You can certainly see kidneys and many of the things that we see at the 20-week scan. And sometimes you can actually see it better at 12 to 13 weeks, especially if you're doing a transvaginal ultrasound, and in some cases, particularly women with a high BMI, this is actually your single best chance to get a really good look at the fetus, because by 20 weeks, a transvaginal scan is really not going to give you the right access, and you're just limited to transabdominal scanning. Of course, because the baby's in an earlier stage of development, you're not going to pick up everything, because there are some things that are just not visible till after 20 weeks, such as the corpus callosum. And then there are often things that just evolve, such as ventriculomegaly, that you can't see. So this group have tried to categorize these structural malformations by how well you would detect them in first trimester. So there are some things that you would expect to detect in all babies at 12 to 13 weeks, and that's acrania or anencephaly, ectopia cordis, anencephalocele, and then some other things that you would want to detect at least 50% of the time, and then other things that are more variable. And if you do that first trimester anatomy scan towards the end of that window, so at 13 weeks rather than at 11 weeks, your detection rate goes up. And that's what we've observed in, well, I work entirely in the public sector at the Mercy, but certainly my colleagues who run private ultrasound practices, they would much prefer someone who was having NIPT at 10 weeks to come at 13 weeks for their early anatomy scan, not 11 weeks. So what about other countries that have a different model? So in the UK, they have advocated NIPT as a second line screening test after the first trimester combined test, and that's so that they can manage costs and continue to offer that first trimester scan. So it's a bit more affordable. NIPT is still quite expensive. If you do it this way, you really probably only end up offering NIPT to the sort of 3 to 4% of women who screen positive on the combined first trimester screen, and therefore you'll save money and you'll reduce unnecessary diagnostic testing from false positive first trimester screening results. But your overall detection rate won't be improved. It'll still be the same as the combined first trimester screening detection rate, because that's how people enter the diagnostic pathway. So you're not taking advantage of the high sensitivity of NIPT, only the high specificity. So what are we doing in Australia? I'd be keen to hear from you all about what your practice is like. And I think it looks very different depending on your population and the demographics of your area. So, you know, if you have the Rolls-Royce model where cost isn't an issue, you know, women will be self-funding NIPT. They'll still be having the 12 to 13 week ultrasound. And if everything's, you know, screens negative, low risk, then no further testing until that 20-week morphology scan. If there's any concerning feature, diagnostic testing. If you end up with a failed NIPT result, which still happens in about 2 to 4% of women, then you're still early enough to offer first trimester screening, combined screening, or repeat NIPT. So this model provides the advantages of both NIPT and ultrasound, but of course it has the highest direct and indirect, the highest direct costs to the patient or the woman. So we've done some research to actually see what's happening in Victoria. This is our perinatal record linkage study that looked at patterns of use in 2015. So there were 79,000 births in Victoria in that year. And of these 79,000, 83.4% had a screening test. So that's been pretty stable. So about 83. And of these 83%, 73% were having the combined first trimester screen, and 20% were having NIPT as their primary screening test. Only 5% were having second trimester serum screening, and 1.3% actually had both combined first trimester screening test and NIPT. How did these screening tests perform? Very happily, they performed as we would expect from the literature. So the first trimester combined test had a close to 90% sensitivity and about a 3% false positive, screen positive rate for the 3 common autosomal aneuploidies. NIPT, you know, amongst the 12,000 who had it as a primary screen, there was a 100% detection rate and a very good specificity and a low screen positive rate. But you can see that if you include high chance results for the sex chromosomes and failed results, if you count them in your screen positive group, because they're the ones that need the follow-up counselling and discussion about further testing, the screen positive rate is actually not that different from the combined, or the first trimester combined test. So I guess that's sort of interesting to compare, because people talk about the very low false positive rate with NIPT, and that's true if you're just looking at chromosome 21, but once you start adding more chromosomes and conditions onto the panel, your screen positive rate will go up. So what's happening now? So that was 2015. We've just been looking, this is unpublished data, but we've got data from the Birthing Outcomes System. That's a maternity database in Most public hospitals, not used at the women's, but we've got this research data set, which we set up during COVID. And when we looked at the aneuploidy screening patterns, we're still sitting at 83% of women having some form of screening, and 15% declined and 2% not offered screening. And the people who chose NIPT, so now you can see the proportions are reversed. 75% of women are having NIPT as their upfront primary screening test, and 20% are having the first trimester combined test. And the second trimester serum screening is still, sitting around 5%. And as you're probably aware, these tend to be less advantaged women. So these are women who turn up for antenatal care a bit late, having missed the boat for first trimester combined test, and then not being able to afford NIPT. So NIPT, in terms of the demographic factors, was associated with being younger, nulliparous, living in a higher socioeconomic region, and being born in Australia, Northeast Asia, or Europe. So we'll be doing a bit more analysis on that, but it's interesting just to see how dominant NIPT is now. Certainly, those proportions are certainly reflecting what I see in the referrals to the Mercy. So what's everyone out there doing? As part of an Australian Research Council grant on the ethical, societal and regulatory aspects of NIPT, we did a survey of healthcare professionals. We've also surveyed consumers. That'll come out separately, those results, but that included GPs, yourselves out there. Perhaps some of you participated in the survey, RANZCOG fellows, and you can see here we had also a small number of genetic counsellors and clinical geneticists and midwives respond to this survey. So about one third GPs and about half obstetricians. And fairly evenly divided into public only, private only, or public and private practice. We had representation from all states, and of the people who answered, the vast majority were actively involved in pre-test counselling, consenting and returning results to women. So this is one of the questions which I thought would be most relevant to this talk. How do you offer NIPT? 60% are offering a choice between NIPT and combined first trimester screening, and 19% are offering it as a first-line screening test for all patients, without posing it as a choice, just saying this is what the best test or a test for you to consider. So, and then about 10% are sort of offering it after combined first trimester screening. So a bit like the UK model, just trying to balance cost, I guess, with reducing unnecessary diagnostic testing. And then how many people are having the kind of nuchal scan on top of the NIPT? But so 86% of survey respondents also still order the 11 to 13 week scan for an early structural survey concurrently with NIPT. About 29% do the 10-week pre-NIPT scan. So some of you might be familiar with that. Some of the private ultrasound practices bundle up NIPT with a scan as well. So you send them in, they have the scan, check the baby's still alive, check there's nothing kind of grossly abnormal, and then do the send off. They may send off the NIPT for you. So that's a slightly different model. But, interestingly, almost 30% are doing that as well. How does that translate nationally? This is kind of just Medicare item number claims for the 11 to 13 week scan, the nuchal scan. That's the grey bars here. So you can see that since 2013, that's when NIPT became available, it's remained pretty steady. So in Australia, at least, it hasn't changed too much, unlike, the Netherlands, where they stopped doing them and saw a subsequent increase in late detection of major anomalies. The blue bars are MBS claims for serum screening, either first or second trimester serum screening, with, and there's been a 40% reduction since 2013. So that's kind of how the landscape's evolving. It's very hard to get good population-based data on screening, but I hope this kind of fits with your experience about what's happening and what standard care has become in Australia. So the other interesting thing that we wanted to find out from the survey is, do people offer a choice? You know, do you discuss trisomy 21, 13 and 18, and then do you ask about fetal sex, sex chromosome conditions, genome-wide NIPT, 22q deletion syndrome, etc. So 53% of respondents said they offer a choice of conditions, and the most common, things discussed amongst those who offer a choice are the sex chromosome, aneuploidies, 85% here, and a significant proportion are also offering genome-wide NIPT. 31% of the survey respondents are also offering microdeletion screening. 15% said they're offering single gene disorders. That response to me is a little bit surprising because there actually isn't any onshore provider of NIPT for single gene disorders. That's still something pretty out of the ordinary that has to be accessed overseas. So I wonder whether there's maybe a little bit of confusion between the microdeletions and the single gene disorder screening there. So that brings me to kind of, I guess, the different technical platforms for NIPT. I'm sure you're familiar with your particular provider. I think what we have seen in this survey is that people like to just stick with something familiar. The most common reason for choosing a provider is the clinical support that they get from the lab after an unusual result. So I hope you guys all kind of might have been familiar with which test goes where, but I'll go through what each of these platforms means if just to recap for you, but the major differences are the ones that are based on massively parallel sequencing, targeted chromosome targeted sequencing, and single nucleotide polymorphism targeted sequencing, or SNP-based NIPT. So the whole genome sequencing, or massively parallel random sequencing, is the Percept and Nest platforms. And the way this works is it sequences everything in the maternal plasma, doesn't distinguish between whether it's come from the mother or the placenta. It analyzes where those fragments of DNA have come from, so maps to all of the 22 autosomes and the 2 sex chromosomes. So you can check any chromosome in the genome that you wish to, and this is what's typically called genome-wide NIPT. So Nest, Percept, Maternity, T21+, these are some of the other providers and generation. In contrast, chromosome-targeted NIPT really will only look at what it's told to look at. So that's the Harmony test. There's a kind of an amplification reaction similar to a multiplex PCR reaction. So you're really only looking at a template that is selected for your particular chromosomes of interest. So you're not going to find anything you're not looking for. So that's kind of a much simpler approach. It won't give you will not give you as many unexpected findings as the genome-wide approach. And then the SNP-based approach, and that's Panorama, that is based on single nucleotide polymorphisms. So it's like DNA fingerprinting. So if you think about what we do in forensics, it's pretty much the same, but from maternal blood. So they separate out the maternal plasma from the maternal white cells. So then you can actually tell what's maternal from the cellular portion, and then what's a mixture of maternal and fetal from the plasma portion. And they deduce what the fetal genotype is by subtracting what they see in the subtracting what they get from the maternal cells from what they see in the placenta. So it's slightly more complicated, and certainly earlier on would have a higher failure rate. But as you can imagine, you can actually get quite a lot of information out of this if it works well, and depending on what you're looking for. So this is where you can actually, if you have a paternal sample, you can even determine paternity. And with twins, you can also get other information. So these three platforms, you don't need to know much about them, but it helps you understand why some NIPT results can give you information and others can't. So the SNP-based NIPT will distinguish between maternal and fetal DNA, and it can detect triploidy. And that's something that the other two platforms cannot do. Subchromosomal imbalances, so they're missing or extra bits of chromosome. You may have a missing short arm or even a much smaller fragment that's deleted. That can only be detected by MPS-based NIPT or genome-wide NIPT. Twins, pretty much all of them are approved for use in twins. Triplets is a bit different. It depends on your provider. Generally, I know some of them are happy to do triplets, but they definitely want chorionicity information so they can help interpret what's going on. And it's definitely worth checking with a lab before you send off a sample so you're not wasting your patient's time or money. Maternal cancer, now that's been well reported as something that's been detected incidentally from NIPT because, of course, tumours can be aneuploid and you can get a very abnormal plasma DNA profile if you have a maternal cancer present. And that's something that will be picked up by genome-wide NIPT because that just analyses everything in the blood. It's not selective, so it will pick up all sorts of things. And then the last little feature here, can you distinguish monozygotic from dizygotic twins? Can you tell someone if they're having identical or non-identical twins? If you have a think about which platform can do that, well, it's the one that does the DNA fingerprinting. So that's the SNP based NIPT. So you can see that there's not one single test that can do all of these things. So when you're using them, it's reasonable to pick any of these three platforms. They will all detect the common autosomal aneuploidies with very good performance characteristics. All this extra stuff, it really depends on your appetite for dealing with extra information and your patient's appetite for extra information too. So in terms of at least the sex chromosome conditions, Ranscog recommends that this does warrant a particular conversation and specific consent to have these done because most people haven't heard of the sex chromosome conditions and they often think they're just checking the sex of the baby. But of course, if you check the sex of the baby, there's the potential to pick up a sex chromosome aneuploidy as well. And these have a much more variable outcome. And so it can actually create a bit more of a genetic counselling dilemma because you're dealing then with a situation of greater uncertainty and variability. Where does Ranscog stand on the genome-wide NIPT? They're not currently recommended routinely because at the time there was an absence of well-performed clinical validation studies. I think a lot of people are using it. This recommendation is really around what should everyone be getting, and Ranscog certainly is not advocating that all women should be having genome-wide NIPT. It's really a down to kind of local practitioner and patient choice. So internationally, we looked from the perspective of the International Society for Prenatal Diagnosis, we recently updated our position statement. So I thought, given that Ranscog's in the process of doing theirs now, I thought I'd share with you what the international community is currently considering standard of care. So we looked at lots of things in this statement. I'll share this for distribution afterwards. It's available on PubMed. I'm not going to go through all of these things, but the areas that people have the most questions about are really about expanded NIPT. Once you go beyond the common autosomal trisomies, what should we be doing? So, ISPD was very happy to endorse NIPT as the most accurate screening test for the common autosomal aneuploidies, and we really just borrowed a evidence-based review from the American Society of Medical Genetics and Genomics because they just did a big review. We didn't need to repeat that. So these are the tables here. Sensitivities very high and with quite tight confidence intervals now that there's a lot of published data out there. So that's fine. And ISPD really couldn't tell everyone how to implement this locally. Of course, it depends on the health system, your funding, and your public health approach to these things. So we didn't try and tell everyone to do a contingent model or a primary screening model. But we did address the issue of expanded NIPT. So trisomy 13, 18 and 21 make up the majority of chromosome conditions. Sex chromosomes make up another 12%, and then there's a sort of a grab bag of about 17% of other types of chromosome conditions that affect other chromosomes, or just what we call subchromosomal imbalances. So just sections of chromosome are missing or duplicated. So the American College were quite keen to recommend sex chromosome aneuploidy screening to all women. The ISPD, we weren't quite as prescriptive, given that we've got a much more diverse readership. So we said it was sufficiently accurate to be offered alongside autosomal aneuploidy screening, as long as you have specific pretest counselling and consent. And of course, there are lots of societal and cultural factors in whether a health service or country wants to offer population-based screening for the sex chromosome aneuploidy. So, of course, in some countries like India and China, it's expressly outlawed, and in the Netherlands as well. And of course, there are downstream impacts of offering screening for sex chromosome conditions that really haven't been studied. We don't know what decisions people make after, finding out their child has a high chance of something like XXX or Klinefelter's. So we don't really understand what the effect of this screening has. So the next bit we tackled was screening for the rare autosomal trisomies. These are called affectionately rats. And they're actually very rare, which is because they're associated with early miscarriage. It's pretty unusual for a fetus to have, say, trisomy 2 and still have a heartbeat and look structurally normal. And what we have found through, our experience with genome-wide NIPT is that 97% of all suspected rats, well, at least on CVSs, are confined to the placenta. So it really is, NIPT is picking up most of the time confined placental mosaicism. So abnormalities that are in the placenta that are not actually in the fetus. So the data now shows that of those women who have a high risk result for a rare autosomal trisomy, only about 11% will actually have that confirmed in the fetus, and the rest are essentially false positives. And what that's led to is in the Netherlands, where they were instituting population-wide, genome-wide NIPT, they've actually decided that they're no longer going to report high-risk results for the rare autosomal trisomies, because it really just doesn't provide much benefit and creates a lot more downstream costs to the patient and the health service. I guess one of the things that pops up, of course, it's never completely simple. If you have a false positive result for a rare autosomal trisomy, and that particular trisomy involves an imprinted chromosome, even if the fetus is euploid, it may have something called uniparental disomy. I won't go into the details, but it's just to kind of bring home the fact that if you're going to be offering genome-wide NIPT, you want to have really good backup from a clinical geneticist and a genetic counsellor, because, it's not just about doing an amnio. All these other considerations and additional testing for UPD might come into play. So I think you just need to be aware that it has the capacity to create a whole lot more downstream investigations. So this diagram actually is just to kind of illustrate what confined placental mosaicism is. Many of you may not have done genetics for a few decades, but essentially sometimes the conception can have both trisomic cells and euploid cells, and their distribution across the placenta and the fetus really impacts whether we would expect to pick it up by NIPT or not. So NIPT is picking up cell-free DNA in the maternal plasma, and that really is, in terms of the pregnancy, just DNA that's coming from the placenta, not from the fetus itself. So if you've got fetal placental mosaicism, you might pick it up in the maternal blood, depending on what proportion of cells are mosaic in the placenta. If it's high enough, you'll pick it up. You might pick it up also if it's in the placenta but not in the fetus. You will then detect this situation by doing an amnio, which will tell you that the fetus is euploid. And then the presumption is that you had the false positive NIPT because of CPM. And then this situation where the fetus is mosaic but the placenta is not, we're never going to detect by NIPT. We don't even know how common that is because, of course, we don't even know to test these children when they're born. So what does it matter if you have a high-risk result for a rare autosomal trisomy, you have the amniocentesis, that's normal, it's not an imprinted chromosome, is that the end of the story? Actually, it's not, because there is an increased risk of some general obstetric adverse outcomes in the presence of CPM. And again, this is sort of relatively new to us, but you know, women with confined placental mosaicism, particularly if it's for trisomy 16, have a higher risk of early onset fetal growth restriction, intrauterine fetal death, so there's now a kind of feeling that some of these women need growth surveillance if they're at high risk of growth restriction. So again, we're just trying to work out ourselves, you know, in tertiary centres, who needs extra scans, who can be reassured and go back to normal routine care. So this diagram here is actually from VCGS. These are outcomes from 120 pregnancies that had a rare autosomal trisomy identified on NIPT. So you can see it gets a bit complex. So what did ISPD say? Really, there's insufficient data to kind of assess the actual sensitivity and specificity of NIPT for the rare autosomal trisomies, and it's not, therefore not recommended for the routine care of unselected populations. Doesn't mean you can't do it, just means we're not saying everyone should have it. And then if you are going to do it, you really need to make sure you've got experts to help you manage the results, people who know what they're doing. So how are we going for time here? I'm just going to go through some other aspects of whole chromosome or genome-wide NIPT. The other thing that it can detect are subchromosomal imbalances, also called segmental imbalances, segmental aneuploidy, lots of copy number variants. It's all can be a bit confusing, but essentially it's just part of a chromosome that's missing rather than a whole chromosome. And whether it's picked up on NIPT depends on how big it is, the fetal fraction, so what proportion of the cell-free DNA in the maternal plasma actually comes from the placenta, and then technical aspects to do with the sequencing depth and the particular platform. So Belgium and the Netherlands, they were the two countries that did population-based genome-wide NIPT screening. They found that the positive predictive value, so the chance that a woman with a high-risk result actually had a baby or a fetus with this imbalance, was 47% and 32%. So 47% in Belgium, 32% in the Netherlands experience, which is about similar to the positive predictive value of NIPT for trisomy 13. So they've basically concluded, well, that's not too bad if it's good enough for trisomy 13. And these sorts of imbalances generally have quite a significant phenotype. They're not on the whole benign things. They will continue to report segmental imbalances. We can't ever really work out what the sensitivity is of NIPT for subchromosomal imbalances is, because we're not testing all babies at birth to see which cases we picked up. So that's the limitation of the data in this space. With Down syndrome or trisomy 13 or 18, you can pretty much detect it on clinical examination, but all of these other things really require genetic testing. So this is what ISPD have concluded. Same as for the rare autosomal trisomies essentially, but acknowledging that there's going to be more data coming out soon from Belgium and the Netherlands to help us on this in this regard. So again, it's not for everyone, and if you are going to do it, just make sure you have the right team around you to help with any unexpected findings. Okay, last aspect of expanded NIPT are the microdeletions and duplications. So they're very similar in principle to those subchromosomal imbalances we just went to, but they're just a lot smaller. So genome-wide NIPT will not pick up microdeletions. So Percept and Nest will not pick up 22q deletion syndrome. You have to have a test that specifically looks for something that tiny. And the most common microdeletion syndrome in humans is a 22q 11.2 deletion syndrome or DeGeorge syndrome. It's present in anywhere from about 1 in 2,000 to 1 in 4,000 pregnancies. So it's the most common one after Down syndrome. These are the other 3 most common microdeletion syndromes. I say the 3 next most common, but they are individually very rare. So Wolff-Hirschhorn syndrome, Critter-Schadt, and Prader-Willi and Engelmann syndrome. So these days you can order NIPT that just has aneuploidy screening plus 22q or aneuploidy plus a panel of microdeletion syndromes, including 22q. There's been a systematic review looking at NIPT for microdeletion and microduplication syndromes, but because none of them were able to test every low risk result, to see what their false negative result was, we can't really calculate specificity or sensitivity. There's only been one study that's actually followed up all low risk results and done genetic testing on them to make sure that they didn't have 22q deletion syndrome. That was done by, that's the data sitting, behind the Panorama assay. They found a sensitivity of 75%, a screen positive rate of 0.2% or 1 in 500, and a positive predictive value of 24%. So for every 4 women that get a high risk result for 22q deletion syndrome, 1 will actually have it confirmed in their fetus. And actually the majority of those true positive cases actually had ultrasound abnormalities as well, because cardiac anomalies are also strongly associated with this syndrome. So, they've also improved their bioinformatics algorithm, and they're now claiming a sensitivity of 83%. But you can see the case numbers are very small, even in this study that had it had about 20,000 women in it. They had 12 affected cases. Sorry, I'll just unless it's someone calling me to tell me to hurry up. So the 22q deletion syndrome, yep, it's only been evaluated properly by one study, and ISPD were fairly cautious and did not recommend it for the routine care of unselected populations. And, it's important to remember that we still pick up, we can still pick up 22q deletion syndrome with ultrasound screening if the fetus has structural anomalies. Okay, so again, it's really hard to make categorical statements about what people should and shouldn't be doing these days, because NIPT, there are many different flavors of NIPT. It's hard to do head-to-head comparisons because no studies, or there are virtually no studies doing direct comparisons of different types of NIPT, because of course no one wants to fund a study to assess themselves against their competitor. And then all the populations in these studies they all vary a little bit. So, it's very hard to know what the true situation is. Also, everything's quite rare, so making adequately powered studies is very challenging. So essentially, RANZCOG saying we're not recommending it routinely. So I hope that helps a little bit with just navigating where we are with regard to NIPT. Of course, pre-test and post-test counselling is key to making sure this is offered responsibly and that people aren't caught unawares by what they've been tested for. And of course, ongoing issues with equity of access is something that we need to tackle. And I think, working out what we should do really should be a conversation with consumers, not just amongst ourselves. So to summarise, NIPT is now the most commonly used first-line screening test in our population. So used in about 75% of women who are having a screening test are choosing NIPT. The ultrasound still has additional value for early detection of structural abnormalities. Getting more complex now that we have expanded NIPT and there's genome-wide options and microdeletion screening. And that if you are offering NIPT, make sure that you do have that specific conversation around whether someone wants the sex chromosomes assessed, and then only offer expanded NIPT if the woman wants additional information and you have the right resources to manage the consequences of that additional testing. So in the interest of time, I won't talk too much further, just showing you that, prenatal diagnosis has taken a big dive since NIPT and is now at a pretty steady state, and that 90% of prenatal diagnoses of trisomy 21 are actually now detected through NIPT. So it really is a very dominant screening test really in our population now. So, and then a couple of resources which I'll give links to. We've got a decision aid that women can work their way through. They answer these questions, gives them a little bit of, a score, whether someone's leaning towards or away from screening, and then what sort of screening test, if they want screening, what sort of screening tests might be right for them. And then they can save those results and discuss them with their maternity healthcare provider. And then we've developed a genetics in pregnancy course for doctors and trainees, even midwives can do it, and it's accredited with RSCGP. So that's available from the University of Melbourne Mobile Learning Unit. So thank you everyone for your attention. Sorry if I've gone over time.
No, not at all. It's just
a
few questions. Lisa, not only do you need a decision-making thing for patients, but also for GPs, it's increasingly difficult. I mean, you have to have the conversation about, do you want prenatal screening and testing or not? So that's part of the conversation. Then you have a conversation about what sort of prenatal testing that you want. And then if somebody actually falls on NIPT, it sort of fell there. But now there's a conversation about, do you want sex chromosomes? Do you want microdeletions?
Yes.
And now there's a conversation really about which test is better for which of them if you're starting to get into issues such as, obviously microdeletions. And so it's really, really complex. And I think it's a landscape that certainly I as a GP am finding it harder and harder to navigate, to provide advice, as well as all of the other things that you do, which is not obviously just about prenatal screening. But I suppose that's my rant. But I think that this world is here to stay for a little while until it settles down a little. One of the questions I was going to ask is, we've just had MBS rebatable from the 1st of November for reproductive carrier screening, yet the inequity around the provision of NIPT is pretty profound. Do you think there's going to be an MBS rebate, and if not, why?
So there have been 3 failed applications for an MBS item number for NIPT, and the reason why it's failed is because we don't have good evidence to make a case for public funding for it, and that's because all the data is kind of sitting in, with various private providers, and we don't collect any population-based data on screening and diagnosis. So with my research hat on, I have, I work at the Murdoch Children's Research Institute, where we have statewide prenatal diagnosis data. So all the amnios and CVSs are we obtain that data because there are only 2 labs now who do it. It's relatively easy. And we've been publishing an annual report kind of showing patterns, but we don't have the screening data. So we don't know.
I might just go through. Yeah, great. I'll go through a few more questions or else I won't get there.
Yeah.
This is an indulgent question for me as well before I go to the panel or the other people that are participants. Can you tell me about the logistics for paternity testing? Because I've had a few patients asking me about that.
Okay. So non-invasive
Yeah.
Paternity testing.
So paternity testing, if they've had a number of partners and they're not sure who the baby, who the fetus, who the father of the baby is. And you mentioned that there was one test that is able to actually test for paternity. Do you know anything about the basics of consent and
So that's the panorama test. They don't market it for that reason, and they may not actually report that to you, but it's something that they can see in the back end if they want to. And in the very early days, they were kind of asking for an optional paternal sample, but then they've stopped doing that, I think, probably for lots of reasons. So it's not really available as a kind of
I've been aware of a few patients that they actually access them, but usually through other doctors. So I was just wondering.
So I can't answer specifically more about that.
Through these questions, but I mean, it's an important thing for people to know in their unusual circumstance. Some obstetricians offer both, early combined screening test and then the NIPS. I don't. I usually just say, one or the other, and then do the 12-week scan. And then as a general practitioner, often GPs do what I do, which is you order your 12-week scan, which is also your dating scan, unless there's something else happening, and then you do your NIPS straight after that, as opposed to obstetricians that often have an ultrasound available. But what's your opinion about offering both an early combined screening test, and if that is low risk, still offering it?
I don't think there's any value in that really, because you're just adding to the false positive rate, really.
So what's the question is the perfect, and it's in what's the best time, do you think, to do an NIPT test and a first trimester screening test?
Look, anytime, it's technically possible anytime after 10 weeks, right up until someone is ready to give birth. So there's no upper gestational age limit. I think it's more around, I guess, how you want it to work with ultrasound. So you could do it after the 12-week scan, because then if you see something abnormal at the 12-week scan, the woman might just need to have a CVS then and there, or you might diagnose twins or incorrect dates, in which case, you haven't wasted your time and money on NIPT.
I feel the same. And also with increased body mass, you might get a lower fetal fraction at 12. I was just going to ask about, this is a great question, are there any known implications of confined placental mosaicism on placental function?
Yes, that's kind of why it is associated with fetal growth restriction. But it does seem to be worse for some trisomies, and I mean for some chromosomes and not others. So not every. So that's why I guess we still don't quite know which chromosomes to worry about. I think we worry about chromosome 16 and 22 when there's CPM for those, but we don't have as much information about the others.
And then there's a few people asking about those add-ons, and yes, depending on what test you're ordering, there are a variable number of add-ons depending on whether they can see it or not. Person's asked about financial options for socially disadvantaged women, but I'm not aware of anything at all.
No, there isn't any actual program for financially subsidising women. But if we had a woman referred to the Mercy with a high-risk first trimester screening result, she really didn't want an invasive test, we would fund NIPT for that woman.
And I'm aware that happens at women's too. And I think that's a really good thing to go out on, which is the fact that all of the 4 services do have genetic counselling services. So the thing is to actually use those genetic counselling services if you need to. And those genetic counselling services are also available for women that are going through private care. So they don't have to be going through care at the hospital. And often just a reminder that you can use those genetic counselling services if somebody's got a family history of something, early on in pregnancy when you don't know what to do. And they're absolutely fantastic and really responsive through all the services. And quite a few comments about a fantastic talk. So thank you very much, Lisa.
Yeah, you're welcome. I'm happy to answer questions sort of by email or something afterwards.
Great. And over to you, Vicky. Thanks very much.
Thanks, Ines. Very nice to see you. Now I'm going to share my screen, so hopefully this will all come up hunky-dory. As you may all know, I'm speaking on modes of delivery tonight, so possibly not quite as exciting as Lisa's very cutting-edge talk. Mine is going to be full of stuff that you probably already know. So I'm hoping, Ines, that you can see that okay. Is that looking all right?
It's looking perfect.
Beautiful. So we're going to talk about modes of delivery, covering a lot of stuff that you all already know. It's probably fairly intuitive knowledge. Going to go through some data, both Australia-wide and local. So just a bit about me. As you heard from Ines, I'm working at the Women's in public and Francis Perry now in private. I head up one of the antenatal teams at the Women's and a medical lead for a couple of other groups. So Bagaruk, which is a caseload midwifery program for our Indigenous and First Nations people. And I'm also the medical lead of the new home birth project, which is fantastic. And I do ultrasound a day a week with having obtained my DDU a little while ago. So I have a fairly diverse overview of it all. So we're going to talk a little bit about definitions, incidents, the reason why different modes of delivery might occur, risks, benefits, some controversies, and just some take-home stats that you might find useful when you're talking to women in the shared care setting. So interestingly, the World Health Organization actually has a definition for normal vaginal birth. And so they define it as spontaneous labour, and the woman begins labour low risk and remains low risk throughout the entire labour. It needs to occur between 37 and 42 weeks. The baby needs to be head down. There should be no augmentation, so no use of syntocinon or pitocin, as they call it in America, no instrumentation, and a very broad brush statement that says mother and baby must be well after birth, whatever that means to you. Typically at the Women's, if we say normal vaginal birth, we just mean it came out of the vagina. And it does not necessarily mean it is truly normal, and it may not be normal for that woman, and it definitely doesn't confirm that it's uncomplicated. And as we know more and more, which we'll talk about a little bit later in the talk, that often they're called a normal vaginal birth and the mother and baby are not well after the birth. So most centres don't require the labour to be spontaneous for the birth to be considered normal. So for purposes of our talk, we'll really talk about a normal birth being a head down baby that was born not using any instruments. So some people call it a non-instrumental vaginal birth. And that could be induced, or it could be spontaneous labour, or it could be either of those, and it could be augmented labour rather. So obviously instrumental delivery is divided up into forceps. We talk about Neville Barnes forceps, Keelan's forceps. There is another kind of forceps called Wrigley's forceps, which are really pretty much not used anymore. They're just a lift out forceps, tiny little pair of forceps. I like them because I've got tiny little hands. Vacuum or ventouse, water birth, home birth, free birth, and then cesarean section and it's all its varieties. So I'm sure most of you have seen these when you've been doing some time in your training for shared care. So Neville Barnes forceps are big and noisy when you get them out in the room, a bit frightening, but usually for the partner of the woman because they're the ones seeing them. The picture I've got there does have a handle on it, which might surprise some of you. That's called a traction handle. I like that. It helps with the direction of pull. It helps when you're small to use something like that, but not everybody uses that. We try to impress upon our trainees these are not the sort of thing that you want to use without good pain relief. So they should usually have an epidural. If they don't have an epidural, you can insert a pudendal block and give it the time that it needs to work. They are best used when the baby is in a direct anterior position. So the occiput is at the front of the maternal abdomen. And very rarely, occasionally, in babies at the direct posterior position and the baby needs to be delivered. Strongly recommended to have an episiotomy done at the time. I know there are some people who will talk about, oh, I got away with doing a forceps without an episiotomy. We do know that of all the things that we do for modes of delivery, the one thing that absolutely definitely increase, or one of two things that increase the rate of third-degree tears is a forceps delivery, even in good hands. And so it is recommended doing an episiotomy is not a guarantee that you'll avoid a third or fourth degree tear, but it helps to direct the tearing away from the anal sphincter. And most forceps are done because a woman has been pushing for over an hour and a half. Either she's exhausted, the baby's compromised, or we're starting to think that I think there's some fairly good evidence that the longer you push, the higher your chances of prolapse later in life. And most people would say that's about an hour and a half. open to discussion with the woman, obviously. Keelan's forceps, you can see, looks a little bit different. It's longer, has a different curve to the blades. There aren't many people doing Keelan's forceps anymore. We had a couple of disasters with Keelan's forceps probably about 20 years ago in Melbourne. And they're rotational forceps, that's the difference. So they're placed on the baby's head, a little bit of pressure applied to sort of lift the baby up off the pelvic floor and then rotate the baby and then deliver the baby into with a corrected position. So you're often correcting the baby from a transverse position into a direct anterior or posterior position. Some people will take it from a posterior position all the way around into an anterior position. Again, they increase the diameter of what's being delivered, so an episiotomy is recommended. Does require really good pain relief. They're quite controversial. They definitely require a good experienced operator who knows how to do them. Certainly Mark Umstad is trying very hard to revive them at the Royal Women's and is teaching anybody who's interested to learn them. And then vacuum ventouse. This is really, from when I started training a million years ago, forceps were the instrument of choice, but really I would say that ventouse or vacuum has become the instrument of choice now. Mainly because it does not increase the diameter of what is coming out, and so it can often be done without an epidural. It is still nice to locally infiltrate or put a pudendal in if you've got time, because you can see that cup, which is the cup most of us would use. It's called a kiwi cup. It's quite rigid and it'd be quite uncomfortable as you sort of wriggle that into place. The lovely thing about a vacuum is it's really, really good if you've got time, the baby's not particularly distressed, for rotational deliveries or correcting position of the delivery, as long as you really know what position the baby's in. It takes a bit of, that's sort of the thing we really impress when we're teaching them. It's not just shove the cup on anywhere it goes and it will come out. It doesn't work like that. You need to be really an expert in knowing exactly what position that baby's in. Is it well flexed? Does it have a degree of asyncretism? And then placing your cup appropriately. The other great benefit is you can just watch that perineum as the baby's being delivered. Don't necessarily need to cut an episiotomy. To let patients know as you're consenting them for the delivery that this is going to cause a chignon, which is a little Kepler hematoma up here on the baby's head, right where that cup is placed. And the big risk is, I guess, that you can do worse damage to the scalp, will end up with this quite broad, widespread subgaleal hemorrhage. And remembering, even just those little chignons can increase the chances of jaundice in newborns. We don't like to do them before 34 weeks. And again, similar sort of indications: fetal compromise, maternal exhaustion, delay in second stage. It used to be when I trained that if there was a degree of fetal compromise, you didn't use the vacuum because you didn't have time to wait for the chignon to develop. I think that's a bit simplistic. We can definitely, most times you've got to think about how long it takes to get someone to theatre for a fetal distress Caesar. The time that it takes to sit and develop a chignon, you've got plenty of time. So I'll just move that on. So I thought we'd just have a little look at some Australian data. I'm going to summarise this to help you with your counselling a little bit later, so you don't have to remember any of these data. But this is the Australian Institute of Health and Welfare, which produce lots of charts about lots of things every few years. And this is looking at the women who gave birth in 2021. And in particular, if you have a look at the bottom of the graph here, the Australian data, and 50% of women Australia-wide had a non-instrumental vaginal birth. And about 12-ish% had an instrumental vaginal birth. And most of those nowadays are vacuum, as we were mentioning before, less with forceps. And interestingly, the big number that is on everybody's tongue at the moment is 38% of women had a caesarean section birth. So I'm not sure how many of you are aware, there has been a lot of chatter in the ONG world globally about what's the right caesarean section rate. And in fact, in the UK, there was a big push for a very long time to target much lower caesarean section birth rate than that. I would say in the last year and a half, it's become apparent, or 2 years, that aiming for that target has actually resulted in more harm. So there's been more babies born with hypoxic ischemic encephalopathic damage. And so the UK have completely gone away from using a figure as a goal for what is the right caesarean section birth rate. No one knows the answer to that, but it is interesting that 38%, is quite a high number of women having caesareans now. So I'll talk you through, I've got some different ways of looking at this. So I'm not going to dwell on any slide. We'll just run through it really quickly. But if you have a look at an unassisted vaginal birth, if you're a prime gravid and spontaneous labour, it's 57% chance of that. You've been induced. Remember this group, unfortunately, the data from the women's, they lump together induced and no labour. So that's our elective Caesar rate. So it's not a super helpful number there. If you're a multi, so you've had a previous vaginal birth, look at that, 92% chance you're going to come in and have your baby on your own. That's where the work is, getting that first baby out vaginally. Again, an unhelpful number because a large part of this group are having elective Caesars. You've had a VBAC, nearly 10%, and some breaches are still sneaking through having vaginal births, which we can talk about later. And that's the incidences of an instrumental delivery. So, nearly a third of our primips in spontaneous labour will have an instrumental delivery, and most primips in that induced no labour group are induced and having an instrumental delivery. So again, if you're a primip, induced no labour, so that includes our elective Caesars, obviously 12% of primips are having elective Caesars. Emergency caesarean section rate, look at the multigravidas spontaneous labour. So if you've had a vaginal birth before, there's not a 0% chance of having an emergency Caesar, but it's very low chance. And I do have some better graphs that will show you this. So I think it's easier to look at if you're a primary gravid or in spontaneous labour, you turn up to labour ward in labour at the end of your pregnancy, you've got about a 57% chance, that bright Royal Women's pink, as I like to think of it, 57% chance of having a normal birth, and about a 30% chance of an instrumental delivery, and then a much smaller chance, about 13% of having an emergency Caesar. And then if we look at this is women's data, if we look at women who are induced or no labour, you can see this purple colour down here is elective Caesars. And that is, I think I've got this written somewhere, about 12%. And if we have a look at what's left, you can see roughly about a quarter of women will have a normal vaginal birth, a quarter will have an instrumental. So about half of them are getting babies out vaginally. And then there's this little bit of the pie here, which is an emergency Caesar rate of about 38%. If you're a multigravida, so you've had a vaginal birth in the past, as we sort of alluded to at that beginning slide, huge chance that it's all going to go pretty swimmingly, and little tiny 2% emergency Caesar rate there. If you've a multi and you're induced or no labour, keep in mind that this is the elective caesarean section rate. So interestingly, there's a similar emergency caesarean section rate, a few multis needing instrumental deliveries if you've been induced. But again, most women are going to get their baby out without any assistance from us. This is the Royal Women's data. You can see with women, so this is where, having had one previous Caesar where the rubber really hits the road, most women are going to opt for an elective repeat caesarean section. That's that big purple colour at the bottom of the circle. And of the women who attempt, so the women's data over the last 3 years tells us that about 65% of women attempting VBAC at the women's will have a vaginal birth. Our biggest problem is that not many women are actually choosing to have a VBAC. So if you've got an elective caesarean section rate there of 63%, it's a lot of women who are not rolling up for a VBAC. So why would you go for a normal birth? The reason women I talk to choose it is it feels like the natural thing to do. It's your body was made to do it. You recover quicker. You go home sooner. So at the women's, you're not in for very long, 1 or 2 days. A little bit longer in private, less analgesic requirements after birth, and that obviously less strong analgesic requirements, so less bowel, constipation and all that sort of stuff. Less risk for future pregnancies, and in particular, we talked about that. If you've had a vaginal birth before, you've got a really good chance of having a vaginal birth the second time. So you, as we always say, buy yourself a vaginal birth for the future. Home births, this is one of my babies. So my job is to convince all the other obstetricians at the women's that this is a safe thing to do. You may know that there have been 2 very successful home birth programs running in Victoria publicly for quite a while. Many obstetricians that I'm colleagues with have a fear of home birth because our experience of home birth was when we were registrars on a public hospital, labour ward, and someone came in with a midwife who was not associated with our hospital. We'd never seen the patient during pregnancy. We didn't have any of her information, and she came in at 42 weeks, had been at home in labour for 4 days, was refusing everything, and it's really difficult. That is not what normal modern, well, I shouldn't say normal, it's not what modern home birth looks like. So the Royal Women's have mirrored really the fantastic program that Sunshine Hospital been running for a decade now, where women are cared for in the hospital, have all their antenatal visits in hospital, and are assessed for suitability for participation in the home birth program. So at both Sunshine and the women are registered for caseload midwifery program, so they need to be eligible for that to begin with. And at the very first booking visit, all the models of care are discussed, including shared care, and home birth now is added to that. Basically, what they're told is just if you're interested in home birth, flag it for us during their pregnancy. At 36 weeks, all women will have a visit with a doctor. There's a few of us who are registered to do that. And we have a very strict list of things that it's long list that we go through with women, with the midwife in the caseload midwife in the room with us. And we discuss all of those. And one of those things that we have to document that, and I think we're getting the patient to sign a consent form to say that they understand everything we've talked about, including the reasons for leaving the home, and they need to agree to all of those. They can't have a home birth unless they've done a glucose tolerance test and a GBS swab, so they are mandatory, which for a cohort of people who are interested in home birth doesn't normally always fit with that cohort of patients, but they're the requirements we've set. And then if they're assessed as suitable by the obstetrician in the clinic, then the midwife will go out and do a home visit the following week. And there's, again, a very strict criteria list of what makes a home safe. Is there good mobile phone reception? Can we access the house with an ambulance trolley if we need to? If you want to use a birthing pool, is there room to move around the birthing pool? Is there somewhere to lock a dog up? What's happening with small children? And the list goes on and on. But women, the data that is in from the Sunshine program now is that it is in fact safer than having a baby in hospital. And that is probably good patient selection, I would say. And many women love it. It's relaxed, it's comfortable, it's private. You have a midwife caring for you that you know and who knows you. It can normalise birth. You can have your family by the side. And obviously from a medical point of view, it saves hospital beds, but it has been shown less caesareans, less instrumentals, less tears, less postpartum hemorrhages. Free birth I've put there just in case you hear about it. It's not something I think is a great idea. These are the people who give birth with absolutely no medical attendance whatsoever. At home usually, or beside a river. So why would you have an elective caesarean section? The biggest reason for an elective caesarean section these days is repeat elective caesarean section. You've had one before, but obviously breech presentation. We would encourage all women who have a breech baby at 36 weeks to have a conversation about ECV, and every major hospital runs an ECV clinic. There are some naturopathic methods, including moxibustion and acupuncture, that might be useful to help turn a baby that's breech. And I know certainly I'd be interested to hear what they're doing over at the Mercy, but certainly at the Women's, we are currently on the labour ward staff. We're currently having conversations about whether we retrain all of us back up to do vaginal breech deliveries and bring vaginal breech deliveries back in as a possibility for women. Obviously, multiple pregnancy, women can choose a vaginal birth, but a lot will end up choosing a caesarean or be recommended a caesarean. Suspected macrosomia is always tricky because ultrasounds are not perfect. A fibroid obstructing access of the baby's head to the lower segment, and obviously maternal choice, which we'll talk about in a moment. Emergency caesareans are done for failing to progress, obstructed labour, non-reassuring CTG, abruption, cord prolapse, failed instrumental delivery. So they're the common reasons. You may have heard of maternally assisted caesarean section. This is a photo of a maternally assisted Caesar. You can see the mum is gowned. So she's essentially has her arms scrubbed just above the elbows. A gown is placed on and surgical gloves are placed on her by other people. She has a spinal working at that stage. She tends to sit with her arms up. And the surgeon makes the incision and delivers the baby to shoulder level. Then mum reaches down and pulls the baby out herself. I haven't gotten on the bandwagon with these yet, but I am told by colleagues who do them that the women find that sense of involvement is really rewarding. So obviously it's a surgical procedure and the risks are as such. So bleeding, and blood transfusion. Clot in your leg that can go to your lungs, as I always say to patients with DVT, pulmonary embolus, scar, infection, either urine, chest or wound infection, damage to other structures, bladder, bowel would be the common ones in the area. Risks of the spinal anaesthetic, there is a slower recovery, there's no doubt about it, and risk to future pregnancies. So we worry about scar rupture if you're going to have a labour with the next pregnancy, scar ectopics and placenta accreta, particularly with women having lots of caesarean sections. Main reasons, the benefits for them, a lot of women who choose a Caesar will choose because they like the idea of having control over when their baby's born, where there is very clear evidence that there is, oh, sorry about that, guys, very clear evidence that there is less risk of hypoxic ischemic encephalopathy to the baby, less pelvic floor damage. Mums like the fact that they're making the choice, and it's usually over and done within an hour, so it's nice and quick, and that appeals to some women. So I'm going to be, this talk will be finished very quickly, I've realised, and I'm sorry for that, Ines, if I'm not, but you'll all get home and offline much quicker. So I just thought
I'm sure we can think of lots of questions. I think, lady, don't worry.
Should we consent for vaginal birth, and what would that look like? Should women be allowed to have a caesarean section upon request, and should that differ between the private and the public system? Should we allow induction at 39 weeks? What about the ARRIVE trial? And what about pelvic floor protection? What do we know about that? So, as you all know, these are some articles from this year. This is all the stuff that's been popping up in the media, that birth trauma has been talked about a lot. And as you all know, there was the huge inquiry that was done in New South Wales, and lots of women fronted up to that inquiry and spoke about their trauma from their births. And so just because we think we know how women should have their babies doesn't mean that we're right. And I think we've got a lot of learning to do about talking about modes of delivery with women. And so the concept of should we consent women, is birth trauma a result of not, a lot of the things women said is, I just didn't know what could happen. So what level of consent should be aimed at women attempting a vaginal birth? And Hans Dietz is a very well-known Australian urogynaecologist. He's quite well known for having some pretty good flamboyant, well, not flamboyant, but he's very worried about pelvic floors, and he does love to stir the pot a little bit about why do we do vaginal births at all. And you know, he wrote this article, and I think it's just something that we're all talking about more and more. The problem with consenting for vaginal birth is, how do you compare an apple to a banana to a raspberry? So a straightforward vaginal birth versus a caesarean section, and in particular, even the difference between an elective and an emergency caesarean section versus a complicated vaginal birth with a big tear and lots of bleeding, are very, very different beasts. So it's not as simple as comparing a vaginal birth to a Caesar. There's a lot more to it. So the people who would say we should not consent for vaginal birth would say, no, it's a normal default process. That's, women have been having babies vaginally for thousands and thousands of years. It's, if you do nothing, that's what happens. So you shouldn't be consenting for that. The proponents of the yes camp would say things can and do go wrong, and women should be aware of what the possibilities of those things are, like they are for any other procedure. And we consent for less. We consent for giving iron infusions. There's a signed consent form for that. There's a signed consent form in many hospitals for anti-D. So why not for vaginal birth? The problem is, what would you include? So I've put my list of what you should probably include, but this is me saying things. I don't know that I'm right. Women probably need to know that we're going to do regular vaginal examinations during labour, that they possibly will need CTG monitoring, which means you'll have 2 belts around your belly and you can't go in water immersion. There is a risk of tearing the perineum. I quote to my patients 80 to 85% for primogravidas, and in preparing for this talk, I saw that the Royal College, the British College, says that 90% of primogravidas will have a degree of tearing. And we know that about 5% of women will have a significant tear, so a 3rd or 4th degree tear involving the anal sphincter. The risk of lifelong prolapse. So we think probably half of women have a degree of lifelong prolapse. That's not all women having symptomatic prolapse, but certainly you're more likely to have prolapse if you have a vaginal birth than a Caesar. Odds ratio of that's somewhere in the vicinity of 9 to 12 times more likely. There's a risk of emergency caesarean section, as we looked at before, of about 20% or thereabouts to 25%, depending on whether you're induced or augmented or not. There is a risk of instrumental delivery. It runs at 12 to 15% in most institutions. There's a risk of hemorrhage. You know, the women's we're running higher than 30% at the moment for postpartum hemorrhage. Most of that's minor postpartum hemorrhage, but there's obviously the risk of blood transfusion and the risk of fetal hypoxic brain injury. But how much detail do you talk about? Do you go on then to talk about the risk of fecal incontinence? Do you talk about urinary incontinence? Do you talk about scarring along an episiotomy line and the possibility of sexual dysfunction or discomfort or treatment that might need later on down the track? Do you talk about the risk that some women have a retained placenta and need to go to theatre afterwards? Do you talk about the very, 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 very rare risk, but devastating risk of hysterectomy? Do you talk about shoulder dissociation? Do you talk about meconium aspiration, which don't happen that often? It is really difficult. And I have certainly seen written consents for vaginal birth by 2 of my private colleagues that go for pages and pages and pages, and they send women home to read those and bring them back signed. So I'm not providing an answer in this talk, but I'm certainly throw that out there for thought. I think we probably need to be better at being honest about talking about perineal trauma and what being in labour looks like. So examinations, pain relief, and the realistic numbers that, people are genuinely surprised when I say the chances of having an instrumental delivery are X. And so I think it's really important that they know that.
While you're just talking about perineal trauma, do you just want to talk about evidence-based interventions to decrease perineal trauma? Because I think that, we often don't know about that as GPs.
Yeah, so it's really interesting, Ines, because you and I both know we've been talking about this a lot at the Women's. So we're looking at about a 5% rate of a 3rd or 4th degree tear. The 2 things that might increase that chance of that happening are, interestingly, forceps and water birth, actually. So we had a real run, and the international literature would back us up on that at the Women's, that water birth, unfortunately, is a little bit more associated with 3rd degree tear. So we've had a lot of chats at the Women's about perineal preparation, so perineal massage from about 34 weeks on. And there's various ways of doing that. Warm compresses applied to the perineum, quite hot actually, compresses applied to the perineum at the time of crowning and birth. Use of appropriate episiotomy. We have special scissors that actually have an angle on them. Interestingly, Ines, at the most recent conference I went to, FIGO internationally, the urogynecologists don't believe that they make as much difference as we all think they do. And so we had really been told at the Women's that the data was really promising, and it looked like perineal massage was probably the only thing that really made a difference. The urogynecologists have claimed that it does make a difference to your perineal tear rate, but it's not making a difference to 3rd degree rate.
I've started to.
We're still not great at it. So we still don't. I think the best thing is to avoid a forceps. But I think, I mean, there are a lot of other benefits to perineal massage. I think it's really good for women to get over the squeamishness of touching that part of their body and knowing what that part of their body does. Perineal massage, probably the best, if you want to talk about it with patients, the best. The one I've seen that's best online is the Mater in Queensland, has a fantastic little facts sheet about how to do perineal massage. The theory is you start at 34 weeks and do it a couple of times a week. The theory behind it that it is sort of gradually stretches the tissues and gives them a bit more give at the time of birth and labour. But I was sort of hoping that I might be able to find that data that I heard at the FIGO conference for tonight, but I haven't been able to dig it back out again, Ines. But it was not as promising as everything we've been talking about at the Women's.
It's just probably for the last few years, there are some women that have been asking me about it and using the balloons on some occasions.
Yes.
What the balloons called, the Epi something.
Epino. So the Epino is about $200, and it's a bit of a balloon. It looks like the hand pump of a Sphygmo. And you sort of put it inside you put some lube on it and put it inside the vagina, and then pump that up, and gradually over the remaining weeks of the pregnancy, you sort of increase the size of that. The instructions that come with it say you should push it out inflated. Our physios would say, please do not do that. Let it down and bring it out. So
it's something I've started to talk to women about perineal stretching now, where I wouldn't have 2 years ago, and also started to encourage them to have that discussion when they go into the midwives, at actually having warm packs between contractions, just in case that's not the practice of that particular midwife.
Yeah, absolutely. Service. And I think, as far as we know, they don't cause harm. I just don't know that they're going to be the silver bullet that we hope they would be. Alrighty, so just out of interest in terms of consenting women for vaginal birth, women choosing their mode of delivery. Some of you may know Julian Savulescu, who's an Australian ethicist actually, who's been overseas for a little while now in Oxford, wrote an article recently in the BMJ and discussing the risks of different modes of delivery. So it's quite a long article, and the ethical framework around maternal decision making. And so who should be making those decisions and who should be allowed to. I think it's such an interesting read. And again, I don't have the answer on that, but I think it raises questions when you're sitting talking with a woman about where you're coming from when you talk to a woman about modes of delivery, remembering it's actually not your birth. And they do talk about the difference between I think it was the Boland decision and then the Roe v. Wade decision, and remembering that material risk is what we should be talking about with women. Should we be inducing everyone at 39 weeks, or should we allow people to choose to be induced at 39 weeks? That's based on what you will all have heard about the ARRIVE trial. I think every second patient wants to talk about it. It was a New England Journal of Medicine published article in August 2018, I think. And, you know, incredible that they got nearly 7,000, 6 and a bit thousand women to enroll in this trial, where they were randomized to, so that was a multi-center trial. They were randomized to induction at 39 to 39 weeks and 4 days, or expectant management. And in the expectant management group were not allowed to be delivered before 40+5 unless there was a medical indication. And, you know, roughly about 3,000 women randomized to each arm. The primary outcome was looking at as a composite of perinatal death or severe neonatal complications. They always know throw perinatal death in. Probably the more relevant is the severe neonatal complications. Secondary outcome was cesarean delivery, but there were some other minor secondary outcomes, which we'll talk about. So the primary outcome, so that's the perinatal death, neonatal composite, so neonatal injury, 4.3% in the induction group versus 5.4% in the expected group. You can see those numbers are a little bit different. Didn't quite meet significance. And in the cesarean group, there's 18.6% of women having an induction had a cesarean versus 22.2% in the expectant management group, and that was a significant number. So contrary to what we had all been led to believe, that induction results in Caesar, and contrary a little bit to the women's data, in this study, less women being induced at 39 weeks. So can I extrapolate this to 38 weeks? No. Can I extrapolate this to 41 weeks? Probably not. This is very specifically looking at low risk nulliparous women at 39 weeks. Keep that in mind. Other interesting findings, that the induction group had significantly less hypertensive disorders. Not surprising. You knock a couple of weeks off, you're going to knock a couple of people with preeclampsia out of your numbers. Interestingly, the induction group reported less pain and less use of pain meds. So if we have a look at, this is the primary outcome table, you can see all the things that fall under that composite outcome for neonatal problems. Interestingly, I think most of us have found this. Can you see that we normally talk about p-values of less than 0.05 being significant? And this was, they used 0.046 to indicate significance in this study. I thought that was really interesting. You could argue it's dancing around about the level of significance, that maybe if you're a baby, you do better if your mum's been induced at 39 weeks, but not the official line from the study. And then the secondary outcomes, you can see we talked about it being cesarean delivery was the secondary outcome, but there was a lot of other ones that were considered sort of minor secondary outcomes. We talked about cesarean delivery. I'll just go back, being less. You can see the p-value less than 0.001. Operative vaginal deliveries, again, didn't quite meet significance, but there were less done in the induction group. And infections were not that different. Infections and hemorrhages, you didn't get more postpartum hemorrhages by having a vaginal birth. So, I think most of us counsel women by saying, yep, it looks like outcomes are at least the same for babies, maybe tiny little bit better in the induction group, less chance of a cesarean section in the induction group, and no change to your postpartum hemorrhage rate. So I think my take on that is, I always say to patients, we don't tell everybody they should be induced at 39 weeks. We don't have the resources, and it's not for everybody. But if there was a reason to be induced at 39 weeks, so in private, hand on heart, we sometimes have things like wife of a footballer, he's playing interstate the next week, should we induce at 39 weeks? I can now say I don't think I'm doing you significant harm by doing that. We talked a bit about pelvic floor protection. Caesarean section does not completely remove the risk of prolapse or incontinence long term, but it significantly reduces it. So if we think half of the women in the world who've been pregnant, not had a vaginal birth, but been pregnant, will develop a degree of prolapse at some stage in their life, may not need any treatment, may not bother them. We know that you're more likely to have problems from that if you've had a vaginal birth, and it is the first vaginal birth or forceps that does the damage. So if you've had a single vaginal birth, one study I read was a odds ratio of 12, and this one was 9.3, the most recent one that I've read. So that's, pretty significant. We talked about those other things earlier. So the stats I use in counselling, I think the red line is what I would ask you to take home. If you're prima gravida, 1/3 chance of pushing it out on your own, 1/3 chance of having an instrumental, and 1/3 chance of having a caesarean section is kind of the take home rate. And women, that's just straightforward, clear, women understand that. We talked about 3rd degree tear rate, varies from hospital to hospital, but it dances around the 4 to 5% mark. It's up about the 6, sometimes 7% mark with an instrumental delivery. And most hospitals are reporting a 65 to 70% VBAC success rate. And a lot of that comes down to good patient selection. So I would summarize just by saying, really, we need to have really honest discussion around mode of birth, not just assume we know what a woman wants at multiple points of the antenatal journey. I usually ask them what their concerns are about birth, because that helps you to really focus in on what it is that's worrying them, because some of those things might not be correct, actually, and we can start to have really detailed discussions that don't need to occur over the course of one appointment, but can occur over many. And I think you need to think about calling in some help from the side, so that in childbirth education is great for that. And I just put a bit in, I'm sure the Mercy and all the other major centres do the same, but we certainly run classes for culturally, linguistically diverse women, and even Frances Perry in private runs classes in Mandarin. So there's lots of options usually for women to access information that you can then help to interpret for them. That is it, Ines.
Oh, don't you worry, I've got a few questions. I'll start off with my own, which is, I frequently have women say, I want a water birth, and then I actually explain to them that actually using water is different from pushing out a baby in water birth. Often we have that discussion, and they're oh, no, I just want to labour or use it. And you talk about the fact that there's very evidence-based, that it's very safe and can be a really good tool for pain control. But the question about pushing your baby out in the water, and you've talked about the increased risk of perinatal sort of tearing. What's the evidence around the safety profile? I know that we only do water births if there's somebody who's actually experienced in it.
Yep.
If you've got a low-risk pregnancy. But in that circumstance, what's the safety profile like?
So the first thing is the selection of the patient, and that's been controversial in itself at the Women's. So we've had recently had a disabled woman say, well, why can't I have a water birth? And the question was, how do you get a woman out of the bath in a hurry? So in fact, we actually were able to make that happen for her, which was fantastic. So sometimes it does require a lot more thought and effort. I think you're right. So the distinction you need, I think that's the first question you always ask patients. What do you mean when you mean a water birth? So some people just want to stand in the shower or want to be in the bath, water submersion during labour, which is, as you say, very, very different to water birth. I don't think the Women's is alone in having very strict guidelines around water birth. So we tell women that you have to be low risk when you come into labour. You need to remain low risk during labour. So no indications for continual fetal monitoring. You can't have continual fetal monitoring in the water. And there must be a midwife who's trained and skilled and registered as a water birth practitioner. It is, I personally feel nervous we're talking about whether we do them in private, because I'm not trained to do them. And I don't have a gut feel for what's happening in that water to help me know, whereas I can just walk into a birthing room and go, oh, something's not right here. I don't have that gut feel for water birth. So it needs to be a midwife who's really experience, and it needs to be a setup for a water birth. So not every bath is set up for a water birth either. So we have water births that are really rapidly draining, and I've heard about these amazing baths you can take the back off them and they drain. So you need to have the setup, the patient needs to be right, and you need to have the experience, and it needs to be something that is continually assessed throughout the labour. The two things that we worry about with water birth are perineal tearing, and that's thought to be because we're not watching and monitoring that perineum very closely as the pushing stage occurs. So you don't have control over the fetal head as it comes out. And we've done a lot of work around that. I'm pleased to say the most recent data that we have from our water birth program is they've had no third-degree tears for the last few months. So that's been fantastic. And the other thing, obviously, is postpartum hemorrhage. So if you're bleeding into water and it's diluted, we know most of us aren't that great at estimating blood loss anyway, and that makes it much harder. So there are some very cool tools being developed that measure dilution and stuff, but they're not in practice yet.
And that idea about the fact that the baby has to be, can't just sort of suck in air as they come out.
Yep.
How, and a baby that's well doesn't do that, but is that a risk of increasing?
We've not had any, we've done lots of water births at the women's. We've had no problems from a neonatal point of view whatsoever. Right. That really seems to be true to the reflexes of babies. Yep.
Right. And I don't know, do they offer it at the Mercy, Lisa? I like to say
water births.
Yeah. Maybe I'm not sure that
my gut feeling is no, because I haven't been involved in any, and no one's using the rooms with the massive bath.
I've got a feeling they don't, and I think Western might, but I'm not sure. So Sharon's just answered that question, saying yes.
Oh, yeah, it is new.
Right.
Okay.
So Mercy's also offering it. I've got a feeling Western do it.
And Mercy's going to bring in a home birth program as well. So
a few other questions. You've asked one of the questions that came up was about the postpartum hemorrhage rates. I'm interested in both of you. It seems to me that the postpartum hemorrhage rate has increased, and it's probably more than just measurement. I have my own quirky ideas about this, but what's the evidence?
So some context. The way we measure postpartum hemorrhage has changed in the last, so if you're looking at data over a prolonged, I would say over the last 5 or 10 years, keep in mind that when I trained, no one measured anything. It was just like, I reckon that looks about 200 mils, which we've subsequently done studies, and that is a terrible way to estimate blood loss. So we now weigh. So I'm sure the Mercy is the same. Every birth blood loss is weighed. We did not used to weigh for caesarean sections, and we certainly didn't used to weigh for elective caesarean sections, and we've started doing that. And given that the official definition that goes into the databases of postpartum hemorrhage is 500 mils or more, we've had this, when we started measuring for caesarean sections, all of a sudden our rates increased. And we knew that was because we had added a whole bunch of caesarean sections to that we had not been measuring beforehand.
But serious postpartum hemorrhage of, is it more than 1.2 litres? That's increasing too, isn't it, compared to 2 days?
Ours has been sitting, so it increased about 3 years ago, and then it's been sitting pretty steady since then. There was a Safer Care Victoria drive to bring down postpartum hemorrhage rate. It did temporarily, but it's really sitting back about the 3 to 4% rate, I'd say. Lisa, would you say we're sitting about 3.5%? I'd say goes up and down a little bit. The problem with places like the women's is we run a placenta accreta service. You get 2 or 3 big placenta accretas in a month, and suddenly you've got massive blood hemorrhage, and then you can run again for a few months and it's not so bad. So, but overall, it does seem to be that those bleeds of over 1,500 mils, which is what the data is looking registers, sits around the 3% mark.
And I think that the increase in total PPH is around the way we're giving birth now, higher cesarean section rates and induction rates and maternal BMI and baby weight. But so that's sort of steadily going up. But the severe PPH,
and how about the good
old sort of steady around 3%.
How about the good old rub of the placenta that I had? that is
good fundal rub. There's nothing better than a fundal rub.
Evidence-based?
It is absolutely. And
a lot of people don't get the fundal rub anymore, do they?
No, they don't, and it's often because there's a lot going on in a room. You and I both know, at the women's it's all computer based. So you deliver the baby, and the poor midwife's off in the corner doing 5,000 bits of paperwork on the computer with her back to the woman. So things like fundal rub just get forgotten along the way a little bit, but that clearly makes a difference. And if you've ever been at a caesarean section and looked at an open caesarean section wound and watched the uterus, the difference once someone puts their hand and gives the fundus a rub manually, you can see blanch and contract under your eyes. It's quite spectacular. And it shouldn't just be used for once someone is bleeding. It's a good thing to do prophylactically at the end. Yeah.
I've got a few more questions we'll run through. The first one, again, is from me. Is that I was interested in that 3 in 1,000 risk of fetal hypoxia for a vaginal birth. How does that compare to a caesarean section rate? And is it only because of the difference? Basically, you tend to do Caesars at 39 weeks. You know, is it the different timing of a vaginal birth versus a caesarean section?
I
unpick those two aspects. Which
I don't have a number off the top of my head for elective Caesars, I'll be honest. I don't know if Lisa has a number, but it is, you know, it's documented that it's lower. And I mean, my understanding is it's because the fetus is not exposed to the risks of the hypoxia of labour, because labour is a really
traumatic event,
hypoxically challenging event for fetuses. And most of them have lots of reserve, and the placenta has lots of reserve, but not all placentas have lots of reserve. And, you know, I was explaining it's a bit like pushing your head underwater in a pool, and you come up for a breath and you push your head under. You can do that for a while, but, you know, you will run out of puff eventually. So that's I just don't know that number off the top of my head, and I perhaps should, but
there is that component also of if you tend to do an elective Caesar, you do it too, you know, often a week or two earlier, so you have that. You know,
I'll make a plea for it being just a week earlier. So please don't come as a patient of 38-week Caesar, because all of us hospitals, we're taking part in the National Preterm Birth Alliance, and we're really strongly recommending our babies are not born before 39 weeks. So sometimes people come in and say, oh, I was told I could have a Caesar at 38 weeks because that's when elective Caesars happen. It's not anymore.
Unless there's a really good clinical indication.
Exactly.
So I just want to comment about ECVs, because I don't think you went through external cephalic birth. What's the evidence behind that, and when would you offer it? Would you offer it to, you know, pretty much everyone, etc.?
Yep, pretty much everyone. There are some exclusionary factors or factors that make it less likely to occur, to work, and a little bit more dangerous. So obviously this is for a breech baby. Most of us would time an ECV for 36 to 37 weeks. We're aiming to do it hopefully before that baby's backside engages into the pelvis, because the key to doing a good ECV is getting the bum up and out of the pelvis. You're not wrenching the head around quite so much as getting the bum up and out. So you need mobility in that bum. So we will still sometimes have a go. I'm part of the ECV clinic at the Women's at 38 weeks, but we know we're up against it. I think some data will say 70% success rate. We do not quote that at the Women's. We quote about a 50% success rate, 50 to 60%. And the checks that we'll do before we embark on an ECV is what is the AFI, so what's the fluid level around the baby? 2 reasons. One, there needs to be enough fluid to move it, and 2, again, that's an indirect measure of placental function. You don't really want to be doing rough things to a baby that's already hanging on by its fingernails. And we do check for nuchal cord. Interestingly, that's really different. Not all practitioners at the Women's will bail out if there's nuchal cord. I tend to not do them if there's nuchal cord, but there are some people who will still give it a go. And they'll have a CTG prior, so that we need to know that there's a beautiful, healthy CTG before we begin. Not everybody has a growth scan before. There are some sites that like a growth scan to be done, so that not dealing with a macrosomic baby, or equally a very small undetected 5 percentile baby. And 50% will go. If they go, the good news is they generally stay around. They don't tend to flip again back. If they don't go, the question is always, do we have a go at a second one? I've had 2 that have had successful second ECVs after a failed first one, but it always makes me very nervous. There is a 1% chance of precipitating an immediate delivery at the time of doing your ECV. So I do say to people, first of all, you have to accept that might be that awful code green lights and sirens, awful Caesar. Like, everyone loses their mind when you call code green and people stop talking to the patient, and it's scary and it's horrible. But also it means you're probably having a baby at 36 to 37 weeks. So now you've got a pretermer.
Yeah.
So you need to accept.
I always say 1 in 200. I have to change that to 1 in 100, do I?
That's what we're supposed to be saying at the Women's. Yeah. So I don't think it is that much, but whatever. That's what we tell people. There used to be a feeling that you shouldn't do it on a VBAC because you're pushing up where the old scar is. There is very good evidence. I don't have the study off the top of my head to quote it to, but there is very good evidence that does not increase the rate of scar rupture by doing an ECV on a woman who's had a previous Caesar. So most of us will have a go at that now as well.
So just a little bit about the home births, just some quick. So do the midwives go home to supervise early in the labour or once it's really established?
They'll be on the phone from early, and the patient will be entered onto our labour ward electronic medical record. So they'll be seen on our labour ward as a labouring patient at home. And then they will go out sort of once contractions, sort of the same sort of advice we would give for coming into hospital. Once they're about 5 minutes, the midwife will head out. There'll be one midwife there for most of it. Once we get to second stage, so once they start actively pushing, a second midwife will come out and join that first midwife. She's there until the baby and the placenta are out and for an hour after birth. And then she will go and so there'll be two there for that duration. And then she will go and then we'll have a single midwife there for 4 hours post-birth. And then that midwife has to collect up all the medications, the oxygen tanks. It's a nightmare.
Okay. So someone asked when it's starting. Ours is starting now, 6th of December. I'm not sure, Lisa, is there going to be a home birth program at Mercy? Don't know. Maybe Sharon can answer that question.
Yes, there is. They've only just started putting together what the program is. I don't know. I'm sure they would have spoken to the Western or the Women's.
Yeah, so it might start. So Women's is starting now, and Sunshine's got a well-established one, which is Western, and it sounds like Mercy will come on later this year sometime or next year sometime.
And I have to give credit to the Western. They've been so generous in sharing all of their protocols and procedures with us, and so I'm sure there'll be lots of collaboration when Mercy starts to come online too with us and with Sunshine.
And so people with that are GBS positive, I presume they can have a water birth, and I presume, yep. Great. And there was something else I was going to say there, but they can have a water birth and they can have a home birth, presumably. That's not
absolutely.
There's a comment about maternal choice for lowest uterine cesarean section in public versus private. I mean, I think you spoke to that a little bit already. It's a joint shared decision making with patients.
It is. That's so interesting, isn't it? When I started 24 years ago at the Women's, we did not do maternally requested Caesars. People were just told no. Then, believe it or not, and I'm a bit horrified to admit this, when people asked for one, they were told they had to see the hospital psychiatrist before we would agree to one.
I remember that.
How seems that now in retrospect. Now it comes to sort of one of the more senior members of the team just to have a visit with them. And it's not for us to convince them not to. It's just for us to go through what's their reasoning behind it. And, for things like pelvic floor protection, making sure they understand it's not a guarantee that you won't have trouble with your pelvic floor.
And it often takes place over a few consultations
exactly.
And that's a really good way for it to happen. And the issue about GPs, there's a question about whether we're actually putting ourselves at medico-legal risk for referring in for women that then actually have a home birth, but the decision is really made at the hospital.
Absolutely.
You're referring them in for maternity care, and then there's a very comprehensive decision making
on well-established algorithms.
That's right. And there's a question here about perhaps doctors could contribute more to birthing classes. So
yes, that's my bugbear. Absolutely. I don't know how many times I've asked and said this at the Women's, could the doctors please come along to a class, and we just haven't got in the door.
And I would like to see more online classes because, by and large, they're absolutely fantastic, but there is a variability in childbirth education classes depending on, what's told and who's giving it and what the particular proclivities of that person might be. So I hope that, in this digital world, we might move to something that's a little bit more accessible in both languages and place and the sorts of issues that we cover. But women often like to have that discussion between other women as well. And I think that live aspect's really important. Is there anything else that, Lisa, thank you very much for those resources. There was quite a few comments saying that the whole prenatal testing, as I said, is getting more and more confusing and it has to be really live and front of mind. But we do need that resourcing, I think, as GPs, both for ourselves and, the women that we serve, essentially. So thank you for providing those. Is there anything else that you would like to leave us with, Vicky and Lisa? The only thing I'd like to leave us with, I suppose, is that, pregnancy and the whole thing can be really joyous. Sometimes I think, as doctors, we're just medicalising everything sometimes and making it so confusing rather than actually just giving a little bit of space for the joy of, you know, growing another human being, and, you know, that relationship that you have that's altered within your family unit that can often be really positive, and this new person that you're bringing into the world, because we're also focused sometimes on the things that are going wrong and potentially going wrong. But anyway.
Just also say that, you know, Lisa's from the Mercy, I'm from the Women's. We're not living in a silo out there. We're really, really happy to take phone calls. If you don't know what you're doing about something, not sure of something, I find the women's guidelines terrific, but some of them are hard to navigate, and they're guidelines. Not every patient fits into a guideline. So, you know, I'm one of 3 heads of unit for the general obstetric units. There's obviously a whole bunch of subspecialty units as well. We're really happy to take calls.
And yeah, and I get, you know, I must get 10
not on your own
every week from GPs saying, you know, or phone calls saying, you know, how, you know, what should we do here? How can we get support and advice? And if I can't answer it, I'll get the right person to answer it for you. I might not be able to do it on that day, but if you can wait for a few days, I'll do that. So there, you know, I think that people certainly, you know, the obstetricians, the counselling services understand how complex it is at that primary interface, giving all of this sort of counselling, all of this advice, trying to navigate this really complex system for women. So please feel free to use, as Vicky said, as Lisa said, you know, the services that you need to in any of the 4 hospitals. And thank you so much for looking after the women that you do in conjunction with the Women's, the Mercy, Northern and Western. So thank you very much. And I won't put the last slide up, but basically you'll be getting the recordings, a link to the recordings, and also the PowerPoint presentations and your certificate in the next week or so. Thank you again to North Western Melbourne Health Primary Health Network. Thank you, Lisa. Thank you, Vicky. Good night, everyone.
Okay. Bye. Thank you, everyone.
Thanks, everyone.